Welcome! Today we're diving into a really fascinating and diagnostically tricky area of medicine, variable vessel vasculitis. Now, what makes these diseases so challenging is that they completely defy our traditional classification systems. They can inflame blood vessels of literally any size, from the massive aorta all the way down to the tiniest capillaries. And they do it unpredictably.
So here's our roadmap. First, we're going to establish what this new vasculitis category is all about and how we got here. Then we'll do a really deep dive into its most famous archetype, Behçet's disease. We'll cover everything from how it presents to how we manage it. And finally, we'll wrap things up by looking at the second key condition, Cogan's syndrome, and some of its really rare and interesting variants.
Okay, so to really appreciate why variable vessel vasculitis even exists as a category, you have to understand the problem it was designed to solve. For a long time, we tried to classify vasculitis almost entirely by the size of the blood vessel it hit. But that system, well, it was just too rigid for a few very complex, very tricky diseases.
And this timeline really tells the story of our evolving understanding. You know, back in 1994, the first Chapel Hill Conference laid out this neat, size-based framework. It was a great start. But over the next couple of decades, clinicians on the ground kept seeing patients with diseases like Behçet's that just didn't fit. They didn't play by the rules. This clinical reality is what forced the issue, leading directly to the 2012 conference, which had to fundamentally rethink the entire system.
And this right here is the solution they came up with. This is the formal definition that came out of that 2012 meeting. Variable vessel vasculitis, or VVV, was officially born. It's a home for any inflammatory vascular disease that can hit vessels of any size and any type, arteries or veins, without playing favorites. And the conference was very clear, naming Behçet's disease and Cogan syndrome as the two classic examples, the archetypes that define this whole category.
So, to put this all into context, take a look at this table. This shows you exactly where VVV fits in the grand scheme of things. You've got your large vessel vasculitis, like Takayasu, your medium vessel, like polyarteritis nodosa, and your small vessel, ANCA-associated vasculitis. And then you have VVV, standing apart because its defining characteristic is its lack of a specific target vessel size. It's the wild card of the group.
All right, let's get into the details. We're going to start our deep dive with the absolute archetype of VVV, Behçet's disease. It was first described way back in 1937 by a Turkish dermatologist, Hulusi Behçet, and boy, has our understanding of it evolved. We've gone from thinking of it as a simple triple symptom complex to recognizing it for what it truly is, a devastating multi-system vasculitis.
The epidemiology here gives us some major clues. I mean, look at that geographic distribution. It clusters right along the ancient Silk Road. This strongly suggests there's some kind of interplay between a genetic predisposition and an environmental trigger. Genetically, the link to the HLA-B51 allele is rock solid. But here's the really critical part from a clinical standpoint. While it affects men and women about equally, the disease is far more aggressive, with a much higher mortality rate in young male patients. That's a crucial prognostic factor to remember.
So what's the number one thing you'll see? It's these recurrent oral aphthous ulcers. We're talking exquisitely painful sores that can pop up anywhere in the mouth, usually at least 3 times a year. They start out as these little red bumps and then turn into shallow ulcers with this yellow fibrinous base. But the key diagnostic pearl? They heal without leaving a scar. Their presence is the absolute clinical sine qua non of the disease.
Now, this slide highlights a really critical distinction. Genital ulcers are also common, but they're different. They tend to be deeper and even more painful than the oral ones. But here's the feature with the most diagnostic punch. Genital ulcers very often heal with deep, permanent scars. And that scarring, that is a highly specific feature for Behçet's disease.
And this right here is why Behçet's is so serious. It is so much more than just a disease of ulcers. The ocular involvement can cause blindness. The vascular disease is what kills people. It has this bizarre preference for causing venous clots, but also causes arterial aneurysms, especially the incredibly lethal pulmonary artery aneurysms. Neurobehçet's is devastating, with a unique tendency to attack the brainstem, and you'll also get this classic ANO arthritis. That's an asymmetrical, non-erosive oligoarthritis that hits just a few large joints.
So how do we diagnose it today? Well, the crucial point is that we've moved away from rigid checklists to this much more flexible, weighted point system. The 2014 ICBD criteria were a game changer. They boosted diagnostic sensitivity from about 85% to nearly 95%.
which means we can now catch those atypical cases we were missing before. It's simple. If your patient's clinical features add up to 4 points or more, you have your diagnosis.
Okay, this is a classic, and I mean classic, clinical dilemma. Differentiating intestinal Behçet's from Crohn's can be incredibly tough because they both can cause ulcers in the gut, eye inflammation, and oral sores. But this table shows you how to tell them apart. The presence of that really destructive panuveitis, the absence of sacroiliitis, the formation of aneurysms, and a positive pathogy test, all of those scream Behçet's, not Crohn's.
All right, so we've covered what Behçet's looks like. Now let's shift gears and look under the hood. We're going to explore the underlying mechanisms that are driving all this destruction. And after that, we'll get into the modern, evidence-based ways we actually manage it, which is tailored very specifically to whichever organ system is involved.
If you look at the tissue under a microscope, the difference between Behçet's and other vasculitis is just night and day. This slide illustrates that fundamental divide. Behçet's is a neutrophilic process. It's all about neutrophils rushing in. It's also non-granulomatous and typically non-necrotizing. This is a completely different pathological signature from a classic large vessel vasculitis like Takayasu, which is defined by lymphocytes and granulomas. This is a key concept.
So how do those incredibly lethal aneurysms actually form? It's a fascinating and terrifying sequence of events. The disease launches this targeted neutrophilic assault on the vasa vasorum. Those are the tiny little vessels that supply the artery wall itself. This starves the artery wall of blood, leading to enzymatic degradation of its middle layer. The structural integrity is just gone, and the result is the rapid ballooning of the vessel into a large aneurysm that is just waiting to rupture. It's a process of wall destruction, not narrowing.
When it comes to treatment, it's all about a highly stratified, multidisciplinary approach, as laid out by the 2018 EULAR guidelines. For the skin and joints, colchicine is your cornerstone. For sight-threatening eye disease, you hit it hard and fast with high-dose steroids and TNF-alpha inhibitors, which have been a total game-changer. And for vascular disease, the absolute bedrock of treatment is aggressive immunosuppression, with drugs like cyclophosphamide. You actually have to be very careful with anticoagulants because of that huge risk of causing a fatal aneurysm rupture.
Okay, we've gone deep on Behçet's. Now let's turn our attention to the second archetype of variable vessel vasculitis, Cogan syndrome. This one is exceptionally rare, but it is a true clinical emergency, and it shares that same hallmark of erratic, widespread vascular inflammation.
Cogan syndrome is defined by this classic triad. It's this unique and terrible combination of inflammatory eye disease, specifically non-syphilitic interstitial keratitis, and severe hearing and balance problems that look just like Meniere's disease. Making this diagnosis quickly is absolutely critical because the disease can race towards irreversible bilateral deafness and fatal cardiovascular events like aortitis with just terrifying speed.
Now, this distinction between the typical and atypical forms is not just academic. It's prognostically vital. Typical Cogan's is a very strict definition. It has to be interstitial keratitis, and the eye and ear symptoms have to start within 2 years of each other. Atypical is everything else, and here's why it matters so much. The atypical form is associated with a much, much higher risk, around 70%, of developing life-threatening systemic and large vessel vasculitis.
Hughes-Stovin syndrome is a really interesting one. It's defined by just 2 things: recurrent blood clots in the veins and multiple pulmonary artery aneurysms. Pathologically, the inflammation in the vessel walls is identical to what we see in Behçet's. So the thinking now is that Hughes-Stovin is essentially an incomplete version of Behçet's. It's like Behçet's stripped down to its most lethal cardiovascular core, without any of the classic skin, mouth, or eye symptoms.
And just when you think things can't get any more complex, you run into something called magic syndrome. It's this incredibly rare overlap condition where a single patient meets the full diagnostic criteria for both Behçet's disease and relapsing polychondritis at the same time. This is a profound therapeutic nightmare because the patient is dealing with the combined morbidities of both diseases, everything from scarring ulcers to collapsing cartilage and even airway compromise.
So to wrap it all up, we've really entered a whole new era. The framework of variable vessel vasculitis gives us the mental model we need to actually diagnose these complex diseases that love to cross boundaries. And when you combine that diagnostic clarity with the power of targeted biologic therapies like TNF-alpha and IL-6 inhibitors, you fundamentally change the patient's future. We've moved from an era of certain, severe morbidity to a future where we can genuinely aim for durable, long-term remission. Let's end with one last forward-looking thought.
Right now, our classification system, even this advanced VVV framework, is based on clinical phenotype, on what we can see and observe. But as our treatments get more and more precise, targeting specific cytokine pathways and molecular drivers, will our very definition of these diseases have to change too? Will we one day classify them not by what they look like, but by what's driving them on a molecular level? That question right there really encapsulates the future of rheumatology and our ongoing quest to understand these incredibly complex disorders.